Hello there. Welcome to KPJ Damansara Podcast, a show for inquisitive minds where we'll be discussing trending health issues with our panel of specialists weekly. If you'd like to share some ideas of topics, please send us an email. Now let's kick off this show.
Hi, my name is Dr. Rajeentheran. I'm actually a consultant urologist. I've been in KPJ Damansara for the past 15 years. I've been a medical graduate for past 3 decades and have been a urologist for almost 20 years. I studied overseas and came down, did my FRCS in Edinburgh and Glasgow, and then I became a general surgeon. I decided to subspecialize in the field of urology. Then I went off to Bristol for a year and I trained there in urology before I came back here. I did quite a number of fields in urology overseas. They include endourology, uro-oncology, which is urological cancers, female urology and incontinence surgery, which includes urodynamics as well, and laparoscopic urology. Okay, basically prostate cancer is the commonest non-cutaneous cancer in the world currently. This cancer is basically when cells start replicating or starts dividing very fast. Normally there's a cell turnover. What cells dies will be replaced with new cells. But in this case, new cells start replicating so fast, it goes out of control and it doesn't tally with the number that dies off. When that happens, the cells start growing out of control and grows out of control, and parts of the cells can break off and starts going to other parts of the body, which is known as metastasis. That is what basically cancer is all about. Now, the actual cause of prostate cancer is unknown, but basically the pathophysiology of what occurs is basically this. It just goes out of control. There may be risk factors, certain race or ethnicity, like the black African Americans have a higher chance of higher risk of prostate cancers and more aggressive prostate cancers. Age also matters. We don't see prostate cancer below the age of 40. Usually it's above the age of 60 or 65. Our commonest age is somewhere around 65. Their family history and genetic factors are very, very important. If a father or a sibling has got prostate cancer, then the risk of prostate cancer increases tremendously, especially if there are many other members of family. Genetic factors is also important. Prostate cancer has been linked to BRCA2, which is also, BRCA2 is one of the genetic factors linked to breast cancer as well. So now there's a link between genetic factors for breast cancer, colon cancer, pancreatic cancer, prostate cancer as well. So now when we see a lot of family history of breast cancer and colon cancer within the same families, we actually ask them to do a genetic screening as well. Prostate cancer may not have any warning signs. Now, about 3 decades ago, we used to diagnose prostate cancer in the very late stage, advanced prostate cancer. That's before the 1980s. So most of the patients used to come down with bony pains and backaches, and then we used to do an X-ray, and we found there's a prostate cancer that is spread widely. So our role is now to try to detect prostate cancer early. So we do what is known as a PSA test, or prostate cancer specific antigen. So in the early stages, there are no warning signs. You may not even have any symptoms. If you have symptoms, it may be symptoms related to prostate enlargement, which is almost the same as BPH. That means you have urinary frequency, or getting up in the night to pass urine and all that. Sometimes you can have blood in the urine, but strictly speaking, prostate cancer, in the very early stage, you may not have any symptoms. That's why there's a suggestion that certain people need to do prostate cancer screening, which is actually a controversial thing when it's done in the population. Usually prostate cancer is more than 50 years of age. Very rarely we see less than 50 years of age. The youngest prostate cancer I've seen so far over the decades of working is a 38-year-old man. But that itself is very, very rare. So usually when we think about a person who has genetic predisposition to prostate cancer, we start doing prostate cancer screening at the age of 40 and above. Now, survival rate of prostate cancer can vary. We are very lucky. If you were to choose which cancer you like to have, you better choose a prostate cancer. Because prostate cancer has got a very long mean sojourn time. In other words, the prostate cancer starts spreading very, very slowly. The mean by which it spreads, the mean, let's say you have localized prostate cancer, the mean for it to be spread to an advanced prostate cancer is probably about 10, 15 to 20 years. So the survival rates are very, very good. But unfortunately, in prostate cancer, the most important thing is we cannot differentiate between the tiger and the pussycat. Most of them are pussycats. That means it will take a long time for it to spread, 15 to 20 years for it to spread. But then there are some which are tigers. Within 5 years, it spreads very fast. So survival rate is very difficult to say. It all depends on the stage in which we see the patient, then we can calculate survival rates. But in localized prostate cancer, it will take a very, very long time. So not always prostate cancer can cause death. So that's why they say a person may not necessarily die of prostate cancer, but may die with prostate cancer. That means they reach 80 years old, they have prostate cancer, and then they'll die of a heart attack or stroke. So when we see patients in a certain age group, we'll decide when do we need to treat this prostate cancer. If let's say we see a patient who has got only a 5-year survival, 8-year survival, they have got many other multiple medical problems like heart attacks and strokes or very high risk, and they have prostate cancer, we actually don't treat them. We only treat them if we know that the predictive life expectancy is more than 10 to 15 years. If our predicted life expectancy is less than 10 years, we go on towards not treating a localized prostate cancer. But if it's a locally advanced or metastatic prostate cancer or advanced prostate cancer, definitely we have to treat. Or localized prostate cancer, we have to see the predicted life expectancy and see, because they spread very, very slowly in most of the people, not always. Localized prostate cancer, I can do either radiotherapy or hormonal or surgery to remove the prostate. Now, if we do that, they can have a higher chance of erectile dysfunction. And also we have to cut off the vas difference. So to have a child after that procedure is a bit difficult, very difficult. You probably can do an ICSI or something like that and try to take from testicle. But usually by this time, this patient's age are about 60, 65, 70 and all. For advanced prostate cancer, we start on hormonal therapy. When we start on hormonal therapy, their sexual libido will start reducing and they start having erectile dysfunction as well. But it is still possible to have pregnancy, but it's more difficult. Let's say we have a prostate cancer, I remove the prostate. Now, this patient can have some amount of erectile dysfunction. But then we are urologists. We know how to assist a person to get an erection. So we can start giving him PDAF inhibitors. They can still have an erection. Or sometimes we have to do injection to the penis. They can have a good erection. There are certain situations when you have total erectile dysfunction, we can still do penile prosthesis. With the penile prosthesis, you can still have good erection and you still can have intercourse. That's what urologists are meant to be. So when we treat prostate cancer, they can't have erectile dysfunction, we can all sort it out. There's no such thing as impossible to get an erection as far as urology is concerned, because at the end of the day, we can still provide a patient penile prosthesis. And with the penile prosthesis, you can definitely have an erection. I'll give you two different examples. At one time, a person who's very promiscuous, sexual promiscuity, has been shown to be related to prostate cancer. And then there were people speaking that, maybe there's some virus or some bacteria, same like, stomach cancer with Helicobacter pylori. So they were trying to investigate, because a lot of sexually promiscuous men were getting prostate cancers. We cannot determine whether it's due to a virus or bacteria. Then about a few years ago, suddenly somebody says that you get many ejaculations, you can reduce the prostate cancer incidence. So everybody feels that they can ejaculate as much as possible so they can prevent prostate cancer. But that's not necessarily true, because it's not based on a very strong evidence. So I think you should live a life like just as normal. When men heard that there's a new study saying that you have a lot of ejaculation, you can prevent prostate cancer, they're so happy because they can ejaculate here and there. But that's not necessary. It's not necessarily going to reduce your incidence of prostate cancer. This is just a study. A study, there are always certain flaws in a study, and the study has to be reanalyzed, and somebody has to reproduce the same study again. Only then we'll start evaluating and saying what level of evidence the study, whether it's level 1, level 2, level 3 or level 4. So I wouldn't put so much on a single study. We still have two distinct, because we know very well very sexual promiscuous people end up having prostate cancer also. So we can't make a conclusion on just a single study. Okay, common cancers in men include bladder cancers, kidney cancers. These are the two other cancers on top of prostate cancer. Penile cancers are quite rare actually, especially in Malaysia because everybody is circumcised. Even those who are not circumcised, it's quite rare actually. It may be linked to human papilloma virus. Testicular cancers, even though it's uncommon or rare cancers, it occurs in a very specific age group between 20 to 40 years of age. Now, between years of 20 to 40 years of age, the commonest cancer is actually testicular cancer. So testicular cancer, although in the bulk says that it's uncommon, in that age group is very, very common. But very, very common is different from saying the incidence. Because the incidence of testicular cancer itself is very low. Then the question comes is, why don't we go and screen testicular cancers? Now, testicular cancer is a success story of chemotherapy. In the 1950s and 1960s, a person has testicular cancer, it starts spreading. Testicular cancer spreads very fast. Within 2 weeks, 1 month, it can already become metastatic or advanced. Now, the success story is in the 1950s and 1960s, if they have advanced testicular cancer, the survival rates may be only 60%, or the cure rates are maybe 60% or so. But since chemotherapy cisplatin came in, we can have a very good success rate of more than 80 to 90%. And if a person diagnosed with testicular cancer is localized, we can even reach a 95 to 99 or better cure rates. That means most of the so-called cancer survivors, most of them are actually testicular cancer survivors. Because the cure rates are so very good now. But if a person comes with a lump in the testicle, they have to come to the urologist immediately. They have to be in the next operation schedule to remove the testicle and then proceed with other treatment. They cannot wait for 2 weeks or 3 weeks if they have a lump suggestive of testicular cancer.
Thank you for tuning in and catch us again in the next episode. For more updates, follow us on Facebook and Instagram. See you!